Hello my dear students. In this micro lecture we will be covering a couple of orthodontic MCQs, doubts that you've had from say dental pulse or your test papers and or just concepts in general. We have attempted at solving a few MCQs and also giving relevant explanations for the same. One such question that we saw that a couple of you had asked was about the study models. Now study models, as you know, are essential diagnostic aids, and in a well fabricated set of study models the ratio between an anatomic portion to the artistic portion is equal to 3:1. You've also had options that say 2:1, but the more popular choice or answer would be 3:1. That is 3 parts of anatomic portion, that is your teeth and the sulcus that have been recorded by your impression, and 1 part of the artistic portion which constitutes your constructed base for your study model, and this has been given by the ABO guidelines. Alright. The next question is on headgears. The question goes as follows: which of the following produces intrusion as well as distalization? The options that were given were combi pull headgear, cervical pull headgear, occipital headgear, and a high pull headgear. The answer to this question would be the high pull headgear, because this produces both intrusion as well as distalization. Now if you look at headgears, they're classified based on the region from which they derive anchorage, and they're also associated with a certain amount of effects both skeletally and dentally that contribute to addressing a particular issue in a clinical scenario. So high pull headgears are often indicated in patients with vertical maxillary excess or a patient presenting with a long vertical facial height. Why is this so? Because it produces intrusion of your maxillary posterior segments or your maxillary molars, which help in reducing the mandibular plane angle. And this is why high pull headgears are given in cases that need both intrusion as well as distalization, and in cases that are having a vertical maxillary excess or a long vertical facial height. Now if you look at the other options, the combi pull headgear is basically a combination of both cervical as well as a high pull headgear, which has a predominantly distalization force. So it's just given regular class 2 div 1 cases where only distalization needs to be carried out. A cervical pull headgear causes molar extrusion instead of intrusion, so it has distalization as well as extrusion, which is why it's indicated in cases with short face syndrome or short vertical facial height. Those cases are ideal cases for a cervical pull headgear because it helps in extruding the molars, which helps in opening the mandibular plane angle, and as well as distalization effect is seen. Occipital headgear is very similar to the high pull headgear, but the high pull headgear derives more so anchorage from the parietal region, so the best answer to this question would be a high pull headgear. This slide is in relation to the question that was asked in the OrthoIncisal, which was I think question number 33, which spoke about interproximal reduction or proximal stripping. It's also known as slenderization or slicing. Now interproximal reduction is indicated in cases that have tooth size discrepancies or minimal space discrepancy. It can also be carried out as reshaping, where you broaden a contact point into a contact area for better stability during finishing. Also carried out or undertaken in smile aesthetics to eliminate black triangles. It is done to create space for curvus P correction and Bolton's discrepancy if it is within the limits of possibility of interproximal reduction and camouflage. So the question was, I think, proximal stripping is not contraindicated in, and the answer was given as large pulp chambers. Actually, large pulp chambers, a high decay rate, periodontally compromised patients are all contraindications to interproximal stripping. But when you say it is not contraindicated in, it naturally becomes an indication. So a minimal space discrepancy would be a better answer if a question is asked such as interproximal stripping is not contraindicated in a particular scenario. Now another question was on clear aligners. The question was as follows: Invisalign appliance is now commercially given as directly 3D printing, thermoforming on 3D printed model, thermoforming on cast models, and CAD/CAM. I think the right answer to this would be thermoforming on 3D printed model. Earlier, the clear aligners or Invisalign was thermoformed on cast models. You would take putty impressions, pour these putty impressions, and on these putty impressions, because they gave better details, a cast or a model from this putty impression was over which an Invisalign was thermoformed. But this was the older technique. Right now, the most popular workflow of the Invisalign is that intraoral scan is taken. After the intraoral scan is taken, this is fed into the computer, out of which 3D models are formed using stereolithography, and over this 3D printed model, which is done using stereolithography, thermoforming of the Invisalign is done in a vacuum formed way. So option B would be the better choice, because thermoforming on 3D printed model is the most popular way of commercially manufacturing Invisalign these days. Of course, it is also directly 3D printed, but this is not in all the cases. It's in very specific cases where it's possible, but mostly the Invisalign appliance is commercially given as thermoforming on 3D printed model. There was another question on facial divergence, which somebody had asked that the option was mentioned as between the upper third and forehead, but the right answer is that facial divergence is seen in option C, which is basically between the lower third and forehead, because the definition of facial divergence itself is the anterior or posterior inclination of the lower face relative to the forehead. It's part of the profile or the facial divergence profile analysis as well, where it's classified as either posterior divergent, straight or orthognathic profile, and anterior divergent. Anterior divergent is when a line drawn between the forehead and the chin is inclined anteriorly towards the chin, or if it's posteriorly inclined, then it is a posterior divergence. If it falls in the same line or it's perpendicular to the floor, it's known as a straight or a orthognathic profile. So the facial divergence is observed between the lower third and the forehead. There was a question on second molar extractions, where the question was removal of sevens in preference is indicated in which of the following clinical scenarios. One was mild class 2 div 1, B was in adult patients, C when the 8s were congenitally missing, and D when the 6s are inclined distally. And the right answer to this was a mild class 2 div 1, and an explanation for the same was asked. So remember that second molar extractions are not routinely carried out in orthodontic practice. They are very specific indications as far as the extraction pattern is considered. Now in mild class 2 div 1 cases, extracting the second molars is not a routine choice. It's done in specific indications such as when the second molars could be grossly carious or have poor periodontal prognosis. That would be one. And another reason is when the 8s are actually present and not congenitally missing, as seen in option C. And also when the 6s are inclined mesially. So in cases where the 6s are inclined mesially and when the 8s are present, extracting the second molar would cause a greater chance of distalization of the first molar, where the inclination changes from mesial to distal. Also, it helps in protraction of some amount of your third molars as well into occlusion. They provide the space for the third molars also to kind of erupt or move forward. Very minimally so, but more so it is about a greater chance of distalization, which would be beneficial in a mild class 2 div 1 case. And also, if you consider the choice or the position of the second molar in the arch, it's much away from the face or the profile of the face, because of which you will not have a very large amount of retraction and lip fallback as you would want in a severe class 2 div 1 case, where the first premolars would be the choice of extraction. So you will not have a much larger profile change, which is what you require in a mild class 2 div 1, which is why the second premolar is a choice of preference for extraction in mild class 2 div 1 cases. So the answer is mild class 2 div 1, owing to the reasons that it helps in a greater chance of distalization, the position of the second molar is much away from the facial profile for the facial profile to be worsened or be kind of affected, and also it helps to bring the third molar slightly in a more protracted position. There was also a question on arch width changes and about the arch width in the maxillary arch and about the safety valve mechanism. I just thought I would put these arch width changes because it was not a MCQ per se, it was an explanation that was sought after. So the arch width changes are very important. So when we say arch width, it's basically your intercanine width, interpremolar and your intermolar width. And the intercanine width becomes very important in the development of occlusion. So before the eruption of primary teeth, before complete eruption of primary teeth, there is an increased arch width in both your upper and your lower anterior as well as posterior arch widths before your primary teeth fully erupt. By 8 years, when your 4 incisors erupt, the mandibular arch width is established. What do you mean by the term established? It means that the mandibular arch width is set at a particular value level or at a particular distance, and it undergoes relatively very little changes after this age. It remains relatively more stable. So by 8 years, your mandibular arch width is usually established. It of course varies from patient to patient and also based on gender. Now your maxillary arch width, the intercanine as well as the intermolar width of the maxillary arch width increases between 3 and 13 years. So there is a slight delay in the maxillary arch width. There is also a delay up to almost 18 years when the last pubertal growth spurt occurs, and that delay is what acts as the safety valve when the mandible kind of grows because of the pubertal spurt and the occlusion is disturbed. But in general, there is an constant or an interval based increase in the maxillary arch width between 3 and 13 years, and once the permanent teeth are fully erupted, there's actually a slight decrease in the arch width, and then it remains more or less relatively stable except for the maxillary arch width, which kind of changes at the pubertal growth spurt age to kind of maintain the occlusion in a stable way. This is a popular question on which of the following shows endochondral growth, which of the following shows intramembranous growth, or which of the following shows both intramembranous and endochondral growth. And in this particular question, the options to the question which of the following shows intramembranous growth was maxilla, mandible, sphenoid and ethmoid, and the right answer to this was maxilla, because maxilla is a bone that shows completely intramembranous growth. Mandible, if you consider and you put it according to the table, has both endochondral as well as intramembranous growth, because the condylar cartilage grows with endochondral growth and the rest of the mandible is by intramembranous growth. A sphenoid, the sphenoid bone also shows both endochondral as well as intramembranous growth pattern, and ethmoid is the only bone that has completely endochondral growth. So the best way to tackle these questions on intramembranous and endochondral growth is to kind of look at the table and put them in under whether they are endochondral, intramembranous, and both endochondral and intramembranous. So remember that the ethmoid is endochondral. The maxilla, the cranial vault, the cranial sutures, your nasal bone, your palatine bone, zygomatic bone, and the parietal bone are all intramembranous ossification, whereas your mandible, occipital, sphenoid, and temporal bones show both endochondral as well as intramembranous pattern of growth. Let's take up this particular question. The question is that which is a true statement? The width of the maxillary 4 incisors is equal to 1/8 of the bizygomatic width. The width of one incisor is equal to 1/6 of the bizygomatic width. Intercanine width is equal to the nasal width. And the width of upper central incisor is equal to 1/6 of the bizygomatic width. Now remember that the fourth option is true. It's a true statement. The width of the upper central incisor is equal to 1/6 of the bizygomatic width, and this has been given by a useful adjuvant which is known as the Berry's index. This statement has been given by the Berry's index. Now according to Berry's index, the width of one upper central incisor is equal to 1/6 of the bizygomatic width. A lot of studies have been done, and Berry has given this formula. It's known as Berry's index or Berry's formula. And the last one is the true statement. It's also a statement that gives you a quick fact about the Berry's index, and it's an useful adjoint because it provides means of determining the facial proportions of an individual from the width of the central incisors. Hence, it's used for proportional analysis in orthodontics, as well as a very useful adjoint to bite analysis in cases where you have bite marks that have been involved. So, the width of the upper central incisor is equal to 1/6 of the bizygomatic width is the answer, and it is given by the Berry's formula or the Berry's index. There was also a doubt regarding the caries analysis. So first, let's just quickly brief up what's caries analysis. You calculate predominantly three things. First, you measure the arch length mesial to the first permanent molar. Then you also do sum of the mesiodistal width of the teeth anterior to the first permanent molars, which is the tooth material. Then you calculate the discrepancy between the tooth material and the arch length. And if the discrepancy falls between 0 to 2.5 millimeter, it's a very minimal space requirement that can be easily managed with proximal stripping. Now, if it falls in the range between 2.5 to 5 millimeter, it is still lesser space discrepancy compared to something that's greater than 5 millimeter. So anything between 2.5 to 5 millimeter, you could opt for extraction of second premolars because the width of your second premolars, the mesiodistal width, is lesser compared to your first premolar. And in cases where the discrepancy is much larger than 5 millimeter, you opt for extraction of first premolars because this gives the space, adequate space for retraction of your teeth, as well as for getting good profile changes clinically. Now, you don't undertake extraction of both first premolars and second premolars together. You would opt for only one of the two in a particular arch depending on the discrepancy. Questions on types of forces are very frequently asked. They would give you a particular example and ask you to identify what kind of force this is. Now, someone had mentioned that they have a doubt between what is interrupted and intermittent forces. That is the difference between the two. Now, continuous forces maintain the same force level between your appointments. Say you have given a particular force today in a patient's mouth. The same or at least a appreciable amount of that initial force is maintained throughout till the next appointment. That becomes a continuous force. And an ideal spring or a nickel titanium coil spring for either opening or closing of space maintains this force at a appreciable level of the initial force. So this is a best example for a continuous force. Now, interrupted force is a force which declines gradually to 0 between appointments. So before they come for the next appointment itself, there is a complete decline or a decay of the force, and this is an interrupted force. Now, interrupted forces are also demonstrated or exhibited by your fixed orthodontic appliances like certain E-chains. E-chains are elastomeric chains which are used to close spaces, etc. So E-chains can have their force declining to 0 or decay. There could also be certain springs or other force generating elements that can decay to 0 between the appointment. So before the patient comes in for the next appointment, the force is completely declined. That is an interrupted force. Intermittent forces are forces where there is an interval basically between, or the way or the manner in which the force is applied. Mostly intermittent forces are all patient activated forces, like your myofunctional appliances, your orthopedic appliances, etc., which are worn at a particular time. That is, your orthopedic appliances, your myofunctional appliances are worn only at night to get that, to capture or, to get the best advantage of growth. So it's worn only at a particular time, like say 6 hours a day at night, like orthopedic appliances or certain myofunctional appliances. So this kind of a patient activated force which completely drops down to 0 between intervals, because the force is generated only when the patient wears it. So those kind of forces are intermittent forces. So that is the difference between interrupted forces and intermittent forces. Interrupted forces, the force is still there. I mean, the force generating element is still there in the mouth, but the force completely or rapidly declines to zero before the next appointment. Whereas intermittent forces, by virtue of the fact that they're worn at a particular interval, they're intermittent in nature, and patient activated appliances like a removable plate or a headgear, etc., orthopedic appliances are all example of intermittent forces. There was another question on mixed dentition analysis on whether Tanaka-Johnston, why is it not mentioned under cast, why is it mentioned under, not mentioned under radiographic analysis. So Tanaka-Johnston, as according to the answer, was cast analysis, and it is so because of this classification. So mixed dentition analysis, remember students, can be classified into three ways. You have radiographic analysis. So this is the leeway space or the space that is required for the permanent teeth to erupt are analyzed using radiographs, and the examples for radiographic mixed dentition analysis would be your Nance analysis and Hakaba analysis. Something that's taking values based on just casts and then using a probability chart are your non-radiographic analysis, where there is a probability chart or a predictability chart, like your Moyer's chart, where on the cast you measure the sum of incisors, and then for that particular sum of incisors you check the chart for the amount of space that's available for the permanent teeth. So that is the Moyer's predictability chart. Tanaka-Johnston also has a formula, so it becomes a cast analysis, not a mixed or a radiographic analysis, and also the analysis by Ballard and Wiley. Now there are combination analysis which uses both radiographs as well as probability or predictability charts, and such the examples for combination of those kind of analysis are Hickson and Oldfather analysis and Stalley-Kerber analysis. There was another doubt regarding this particular concept. So the resultant muzzle forces acting through intercuspation of occlusion is called as A, anterior component of force, mesial drift tendency, stomatognathics and gnathics. Stomatognathics and gnathics become study of something, so naturally they're eliminated options. Now there is something known as anterior component of force. This concept is one of a main factor in determining the tooth's position, and the explanation explains a lot of mesial drift tendency because that's also the tenet of this concept. So the anterior component of occlusal force is believed to arise as a result of the mesial axial inclination of the permanent teeth. Now because there is a mesial drift or a mesial axial inclination tendency, the forces of occlusion are dissipated axially and through the front of the mouth through the proximal tooth contact points, and also with the help of resultant muzzle forces. So what is the main interest that has centered around this cause is of ACF, that is the anterior component of force, is that apart from just determining the tooth's position, they've also said that it had a possible role in causing migration, mesial migration of teeth, and subsequent dental alignment, malalignment or crowding at a later stage. And this suggestion was initially given by Stallard, but it was not really measured. So it's a concept that is based on a lot of guesswork, but the objective or the statement, the assumption was that the anterior component of force, while helped determining the position of a tooth in the dental arch, also kind of contributed to mesial migration of teeth and late anterior crowding. Next you have a question on InterIncisal angle, which is basically the angle between the upper and the lower incisors, and the question was that the InterIncisal angle in class 3 cases A decreases, B increases, C remains close to the predicted value, and D cannot be predicted. The right answer to this is that it increases. Now let's look at why it increases in class 3 patients. Now if you look at class 3 patients, they can have an edge-to-edge bite or they can have an anterior cross bite, and if you observe the lower incisors, they're usually either upright or they retrocline. And why is it so? It's because when a patient has a skeletal malocclusion such as a class 3 malocclusion, the nature kind of tries to compensate this class 3 appearance. Now how does it reduce this class 3 appearance? Basically by either proclining the upper incisors and retroclining the lower incisors, but the retroclination of the lower incisors is a more common way of natural compensation to mask this underlying class 3, which nature does. Nature kind of compensates by retroclining this lower incisor. So when this lower incisor retroclines and the upper incisor proclines, but the lower incisor retroclination is far more than upper incisor proclination, then what happens is that this contributes to an interincisal angle to be increased when it is measured. It increases because of the upright or the retrocline lower incisors, which are part of the natural compensation to mask the underlying skeletal problem. And this is why the interincisal angle in class 3 cases increases. There was also a question which was on servo system theory or the cybernetic theory. I have not put the right options in this slide because there were a couple of mistakes with the way the spelling of the author or the year. So it would be better if you could just remember the fact of it. So the servo system theory of the process controlling postnatal growth, craniofacial growth, was actually given by Petrovic and Stutzman in the year 1977. So the options have names that are misspelled, so it would be better that if you remember the right names and the right year. So Petrovic and Stutzman did a lot of studies regarding cybernetic theory, regarding the role of the lateral pterygoid muscle and the retrodiscal pad on the condylar growth rate and on the condylar cartilage. And eventually they gave a cybernetic model or a servo system model for this entire craniofacial growth, and it was given by Petrovic and Stutzman in the year 1977. There were also questions related to incisal liability where the options that confused you was between 7.6 mm and 7 mm of incisal liability in the upper arch. The right answer is, the more popular answer is that it is 7.6 millimeter. If the option 7.6 millimeter is present for maxillary upper incisal or maxillary incisal liability, please opt for 7.6. Now in case 7.6 millimeter is not on the list of options and 7 millimeter is there, since it's the closest to the value of 7.6, it would be better if you opt for 7 millimeter in cases where 7.6 millimeter does not exist as an option. So the incisal liability was given by Main, Warren Main, and the values are that it is 7.6 millimeter in the upper arch and 6 millimeter in the lower arch. Basically it's the difference between the amount of space needed and the amount of space available for exchange of primary incisors to permanent incisors. The last question that we shall be tackling in this lecture is as follows. As a general rule in borderline crowding cases of broad facial types, A. Expansion is carried out, B. Extraction therapy should be considered, C. No treatment is required, and D. Only surgical treatment is required. Now options C, D are completely obsolete options which can be eliminated. Now the confusion is between expansion and extraction. Remember that both are cases or both are treatment modalities that can be considered, but option A says that expansion should be carried out, and this is so in broad facial types because broad facial types are usually low angle cases or they are horizontal growers. Now remember that whenever a patient is a low angle case or is a horizontal grower, they have strong musculature and they're also usually accompanied by normal to shorter facial heights, and in such cases expansion is a viable option, treatment modality, because whenever you do expansion, one of the side effects that accompany expansion is a molar extrusion, and molar extrusion is beneficial in patients having a low angle or a horizontal grower or basically a broad facial type by increasing the vertical height. So this molar extrusion would also cause as a side effect would also help in increasing the facial height. So in such cases, and also kind of matches with the buccal corridor space in these broad facial types. So expansion is a viable treatment option in cases of broad facial type. Of course, extraction therapy also might have to be considered, but more so in severe crowded cases compared to borderline crowding cases. So in borderline crowding cases, expansion can be carried out. It could be slow expansion, it could be dental expansion, skeletal expansion, whatever. Usually, since the crowding is borderline, a dental expansion with just the arch wires also would suffice, but expansion is carried out because, you know, of the reason that it helps in, you know, having a broader arch form which kind of correlates with the broad facial type, and also an increase in the vertical height would happen because of molar extrusion, which is a side effect of expansion. So both would be beneficial for a patient with a broad facial type. So expansion is carried out. So the option would be A, that expansion is carried out as a general rule in borderline crowding cases of broad facial types. So we've covered a majority of doubts that you guys have asked with regard to MCQs and certain concepts. There are of course certain doubts that have not been answered in this lecture owing to the fact that I have not found adequate references for sharing them with you. So once we find these adequate references, I will get back to you with a couple of more questions. I think there are about 4 or 5 questions which can be given out as either a handout or a small micro lecture again. Thank you. Hope all the answers to the questions were clear. If anything else, you can always drop in with your queries.